T4 friends, it is Dr. Olana Bree, and I am actually coming to you from the same time zone as Dr. Lamb, our wonderful speaker for today. So Dr. Lamb has been with us before on our podcast, and we are so glad to have him back. He is a professor of dermatology and pediatrics at the British Columbia, tell me what it is, British Columbia Medical School.
Oh, University of British Columbia.
Dermatology. There you go. You were even giving me a cheat sheet. And he is a great colleague, a great friend, and a great speaker. You guys have probably heard him before, but he's going to be talking about genodermatoses, everybody's favorite. And he's going to be doing the triple threat, the triple trifecta here. So I am going to let him take it away. And I'm excited to learn from him today.
Thanks, Alana. It's kind of fun to talk about different topics, and genodermatoses is one that sometimes people kind of leave it to the end to study because it's so hard to get it into the mind. But hopefully by presenting patient cases and making it, hopefully this will make it interesting, because is this topic a cure for insomnia? We will see. So I have disclosures that don't relate to this talk, and I'll acknowledge that I'm here in Vancouver lecturing from the shared unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Conflicts of interest, none relevant to the talk. I will discuss off-label use of medications. So we're going to talk about genetic and clinical features of select neurocutaneous disease, diseases that can present with freckling, and genetic conditions that can give cutaneous vascular malformations, and do that all in the next 45 minutes to an hour. So how are we going to do this? 3 neurocutaneous disorders to know about, 3 genetics disorders with brown spots, and 3 genetics disorders with red spots. So let's go to the neurocutaneous disorders. Good ones to know because they can happen in real life, and they also happen to pop up more often on board exams and such. This is a baby that presents with a red spot on the left side of her forehead. And what organ systems are commonly affected? If you want to play at home and kind of think what's there, I'll give you a second to think. 1, 2, 3, 4, or 5. If you're watching this recording, you can pause. But if you guessed brain and eyes, those are the 2 organ systems to watch out for. What's happening here? This is something called Sturge-Weber syndrome. It's a sporadic neurocutaneous syndrome that's there. And the clinical features of this facial port wine stain, the brain's affected, gets angioma, but clinically you can get seizures and developmental delay. On the same size, you can get eye glaucoma, which can be more silent, and you want to watch out for that and look for that. What gene is associated with this condition? Well, there's different genes I put here, but this is one called GNAC. And this is associated with not just Sturge-Weber syndrome, but even isolated port wine stains. This is discovered about 10 years ago in the New England Journal of Medicine. They found that patients with Sturge-Weber syndrome had this pathogenic change in the gene GNAC. We also find that in regular port wine stain. It's how much tissue that's involved that involves either just the skin, or the skin, the eyes, and the brain. What does GNAC do? Well, here's the pathway. You can see all these little alphabet soup, but downstream it causes cells to grow. In this case, vascular cells that are there. So it can be subtle sometimes, and if you see this red stain that's here or here, these are the ones that are worrisome for Sturge-Weber syndrome. But this one, which is not as confluent, which means if you take a look at these 2, if you're drawing it with a red marker, you're coloring everything in with a red marker, and then you're very careful to color within the lines. It's very sharply demarcated. But the ones that are not worrisome are the ones that are kind of like not fully colored in, and the borders are not as sharp and distinct. So the ones that are the red stars worry about Sturge-Weber syndrome. The ones that are kind of feathery, they're not as worrisome. And so these are patients where they do have Sturge-Weber syndrome or suspected Sturge-Weber syndrome. And these are patients, the 1, 2, and 3 in the right here, these are ones that are not worrisome at all. And you can tell that on the left side, it's quite dark red. They call these port wine stain after the drink, because it's a darker red. Whereas these ones on the right, they're more of a pink red color, and the borders are not as sharp and not as distinct, and the color isn't as filled in as well. And this patient, and this patient here, these are just a very common benign or harmless birthmark. We call it the nevus simplex, or stork bite, or angel's kiss. Some clinical pearls to know here is that the location does matter. It's just like real estate in Vancouver, and I'm sure real estate in California, location is very important. It used to be taught in medical school. It's the V1, V2, V3 distribution that puts you at risk for Sturge-Weber syndrome. But when people look at patients clinically and they think about it, it's not the V1, V2, V3, it's the forehead involvement. It's where the embryological vasculature is. And that kind of makes sense because if you look at where the blood vessels normally go, that's where the problems can happen. If you look at it in real life, the forehead is not involved. You find that there's no cases of seizures, abnormal development, glaucoma, or abnormal MRI. When the forehead is involved, it doesn't mean you will have these problems, but there's a likelihood of that happening. If you follow the pattern, what happens normally in the embryological vasculature, it kind of makes sense. On the right-hand side here, we see the innervation, the medial, ulnar, radial nerve, and that's the distribution. It does not parallel what we see in the skin. What we see in the skin parallels the normal embryological vasculature, not the neurological pattern. Same thing with the foot. If you look at a port wine stain in the foot, that parallels the embryological vasculature, not the nerve distribution. And it's the same for what happens in Sturge-Weber syndrome. We also can see even deeper into the skin. And there's this case series from a few years ago where they looked at patients who did have forehead involvement, and the ones under 2, 5, and 6, these are the distributions of the port wine stains which are at highest risk for Sturge-Weber syndrome. So if you see a patient that has a facial port wine stain, now we know that depending on the look of it, if it's confluent and red versus the feathery ones that are an irregular birthmark, we can say, oh yeah, the feathery ones, that's not worrisome at all. But even if it is a port wine stain, if it's not on the forehead, they're low risk. But even if it is on the forehead, now we can recognize certain patterns that are higher risk than others. In a sense, by recognizing what we see in our patients, we can almost prognosticate for the future for our patients. So not all forehead involvement is the same, but these are the ones that are high risk. If you have a large port wine birthmark that affects both sides of the forehead, that's risk. But even if it isn't the entire forehead, these are the distributions, the median, the forehead, or hemifacial, that also put you at risk for Sturge-Weber syndrome. Management, what do we do when we see this? Definitely send these patients to ophthalmology. If they have glaucoma, there's sometimes no symptoms that you can see early on. So if they have high risk phenotype, again, the port wine stain in one of these 3 areas, send them for an ophthalmology examination. But currently there's no evidence or no strong evidence for MRI screening for pre-symptomatic patients. So if you suspect Sturge-Weber, if you do an MRI early on, you might even have false negative results if they're young kids. But you have to consider the cost and the risk of general anesthesia. And if they have neurological involvement, oftentimes it's not subtle, it's obvious enough. So this is one where definitely get ophthalmology, but for MRI screening, the evidence is still not that strong. And you can even but definitely you can refer them for pediatrics or pediatric neurology to monitor these patients. Where the evidence is strong for is pulse dye laser to treat the port wine birthmark. Practical pearls here, watch out for neonates that have that pink red patches that are confluent, sharp borders that involve the forehead area. But recognize the benign ones, the nevus simplex, super common, and you don't have to worry about those. And send the high-risk individuals to dermatology, ophthalmology, and pediatrics or pediatric neurology to monitor their neurodevelopment. That's the first neurocutaneous. Let's do another one. A 13-month-old boy with increasing number of brown spots. And this is how he looks. You can see the brown spot near the axilla, a brown spot there in the left lower chest, abdomen, all these brown spots that are there. If you look at the armpit, you see sometimes some little freckling that's there. Which of these are part of the diagnostic criteria for this condition? And there's some trick questions here. This is neurofibromatosis type 1, and the criteria does have axillary freckling. And it must be bilateral if the capillary spots are unilateral. There's a condition called mosaic or segmental NF1, and you want to make sure that you're diagnosing regular NF1 and not just one in a segment. But these are kind of tricky. The answer is 6 or more capillary spots, so it's not 2. Scoliosis is seen in patients with NF1, but not a diagnostic criteria. You need 2 or more dermal fibromas, and then schwannomas are seen in NF2. This is a revised diagnostic criteria of NF1 and Legius syndrome. This is from 2021. And at least one of the 2 pigmentary findings should be bilateral, just to make sure you're not misdiagnosing a segmental or mosaic condition. If you're looking at the capillary macules, this is how they look like, and you need 6 or more capillary macules. Size does matter. If they're not pubertal, it's 5 millimeters or greater. If they're post-pubertal, it's over 1.5 centimeters or 15 millimeters. And here's a kid where you can see all these caffeolae macules that are there. How important are just isolated caffeolae macules? Probably more important than we think, because actually, if you look in the literature, you know they're very, very important. This is a study that came out looking at the predictive value of just having caffeolae macules. If you have 6 or more caffeolae macules and nothing else, you'll find that a lot of these kids will actually meet the other criteria for NF1 if you follow them over the course of 5 to 6 years. So if you just have 6 or more caffeolae macules, this is something to really watch out for and watch these patients, because there's a high likelihood that they may develop the full criteria for NF1. Are all caffeolae macules the same? Well, there's the regular typical caffeolae macules that you see in NF1, and these are the nice smooth bordered oval spots that are there. And you have the more jagged ones that are here. People sometimes would compare them as the jagged one meaning the coast of Maine, and the smooth ones being the coast of California, where Dr. Bree is right now. It does make a difference. The smooth bordered ones, those are the ones that are more typical for NF1, and you want to watch out if you see that. There's a more recent study which looked at risk stratifying these patients. If they're young, if they're less, it's kind of double negative. Age greater than 2.5, no. So if they're younger than 2.5 years of age and they have 6 or more caffeolae macules, then watch out for these patients. Monitor them very closely. Make sure they don't develop other signs of NF1. If they're already older than 2.5 years of age and they haven't manifested all the features, look to see if their caffeolae macules are just the atypical ones. Because if you see the atypical jagged ones, they're at lower risk for having true NF1. If they're all typical ones and they have 6 or more, still keep a close eye on these patients. And this is one case whereby what you see with your eyes can actually predict what's actually happening to the patients in their genetics. Other criteria, freckling in the axillary or inguinal area, and this is how the freckling looks like. And you have to find that either the caffeolae macules or the freckling is bilateral, again, to make sure you're not dealing with segmental NF or mosaic NF. And then 2 or more neurofibromas or 1 plexiform. And here's an example of a cluster of dermal neurofibromas and then 1 large plexiform. The dermal neurofibromas don't come up till about the 2nd decade of life, but the plexiform, they're there from the get-go, right at birth. 2 eye findings, optic pathologioma, and 2 or more Lisch nodules. Oftentimes, you can't see them if they have dark irises, but in this patient with light iris, you can actually see the Lisch nodules. If they have dark irises, you need a slit lamp to see that. And then distinctive bony lesions, sphenoid dysplasia, bowing. So if the tibia isn't strong, it kind of bends. So once the kids are walking, you can see this bowing of the tibia. That's one of the criteria for NF1. Or pseudoarthrosis, which means pseudo-fake arthrosis joint. The long bone, it's bending so much it looks like a fake joint that's there. And then genetic testing. If you find a heterozygous pathogenic variant, you only need 1 gene that's altered to get NF1. Either that or a child of a parent who meets the diagnosis. So here's some features of patients who have NF1, axillary freckling, caffeolae spots, the Lisch nodules, the brown dots here, the plexiform neurofibroma, which can get thicker as they get older, or the regular dermal neurofibroma. You can't touch or push a picture, but if you push this, it's very soft and it kind of pokes in. The good thing about neurofibromatosis is, number 1, if you look at the criteria, if you see the caffeolae macules and the axillary and inguinal freckling, you can make the diagnosis in your office without any genetics. The second thing is that there are good health supervision guidelines for kids with NF1. So if you have a patient where you suspect or diagnose NF1, you can follow these guidelines, almost like a checklist of what to do for these patients. Practical pearl. Watch out if you see an infant that has lots of caffeolae spots. Don't think of that as something, oh, it's cute, it's fine. And definitely patients who have darker skin, naturally, they can have caffeolae spots and that's fine. But if you have 6 or more caffeolae spots, watch out because it could be a sign of something more. Second thing, know the diagnostic criteria for NF1. It's something good to memorize, not just for your board exams, which it's a good, the criteria were made in the 80s and they stood the test of time even before we had genetics. But now we have genetics that helps confirm it. There are still really, really good criteria. So from a clinical point of view, important to know. You can make that diagnosis clinically in your office. But the other reason is that since they're such good criteria, they sometimes end up much more commonly on exams. So it's a good one to know. And know that there are really good guidelines for periodic health supervision for patients with NF1. We'll move on to our last neurocutaneous disorder, and this is a 6-year-old female that has multiple white spots on her skin. She also has early acne, put acne in quotation marks, and she also has a history of seizures as an infant. And this is how she looks. You can see the white spots that are there in her skin. If you look closely, this is not typical acne. There are no blackheads and whiteheads. There are no comedones. In fact, these are actually angiofibromas of the face. What is going on here? These are the choices. If you want to play the game to guess and you're online, you're viewing this afterwards, you can pause this. If you're here live, you can tell that this is tuberous sclerosis. Or now I'll tell you that this is tuberous sclerosis. Well, what is tuberous sclerosis? Tuberous sclerosis is a multisystem inherited neurocutaneous disorder. That's a mouthful. What happens here is that the genes, there's 2 common genes that are affected. And fortunately, they're named tuberous sclerosis complex 1 and 2, so it's easy to remember. But they drive cell cycle growth. So if you have a change in these genes, you have cells that keep growing and growing and growing. Classic triad, you see seizures, and these are from tumors that are in the brain, developmental delay from the seizures, and then facial angiofibromas. That's a classic triad. But what you see in the patient, you have lots of these hamartomas in all different tissues, brain, eyes, hearts, lung, liver, kidney, skin, because the gene that's responsible for this is not working. It's like the gas pedal is constantly on. So here's some of the features on the right. You can see a younger kid, some of these red dots that are there, and as the kid gets older, you see much more of these. Unlike acne, these pop up early in life. We're talking about 4 or 5 years of age. So you see a child that comes in with early acne, worry. It could be a sign of a hormonal problem if it's true acne, or it could be the first sign of tuberous sclerosis. Not all of these patients will have seizures early in life, and the ones that don't sometimes aren't diagnosed until they have this. The photograph here on the right shows the white spots. They call them ash leaf spots. They're actually, the fancy term is a nevus depigmentosis that's there. You can see this here and also here. You can also see what they call confetti-like lesions, white spots all over the skin. What other things can grow? You can have connective tissue that overgrows. So this is usually on the back, and this is a connective tissue nevus called a shagreen patch. It should be a plaque, a shagreen patch. And on the forehead, you have these forehead fibrous plaques. You can have periungual fibromas that are non-traumatic that grow around the toenails. And here you have gingival fibromas as well, and the hypopigmented spots. So if you look at the skin features, right at birth, many of these patients, you can see the numbers are almost close to 100%, have these white spots that are there. And then the facial angiofibromas pop up a little bit later. You get that shagreen patch. This is the connective tissue nevus that's there in the back that pops up later. And the periungual fibromas happen kind of in the teenage years. These are the skin findings that are there. Other findings you can have in the heart. This is a fetal echocardiogram. You can see cardiac rhabdomyomas in utero. So these days, with a lot of good high-resolution ultrasound for patients, for parents who are pregnant about 20 weeks gestation, you should be able to pick this up. When you see a cardiac rhabdomyoma, that means that the patient likely has tuberous sclerosis. You can diagnose this in utero. They can also have stuff in the eyes and stuff in the lungs. In the lungs, this is something called lymphangiomyomatosis, basically overgrowth of tissue that's there in the lungs, and that can be even life-threatening. If you look at more than just the skin findings, but other findings as well, the earliest sign you see is this blue circle, and that's a cardiac rhabdomyoma. If you see that in the patient prenatally, that is a pretty good marker that that the patient will have tuberous sclerosis. At birth, the earliest finding you see there is the hypomelanotic macules, the white spots that are there. So some of these findings that are there will pop up at different times in life. What you'll see as this purple and hexagon right there, that's the epilepsy. They have a very particular type of epilepsy called infantile spasms. A lot of babies will startle normally, but these kids, they kind of pull in or pull out, they cry, and they might have a bit of lethargy after seizing. That's something that we see fairly commonly in children with tuberous sclerosis. Some patients have been diagnosed because they didn't have epilepsy. No one noticed the white spots. They didn't see the cardiac rhabdomyomas. They were diagnosed because of the facial angiofibromas. They pop up around school age. And so it's important to recognize the facial angiofibromas. If they're not diagnosed before that time, that could be another entry point where they get the diagnosis of tuberous sclerosis. Now, the white spots that are there, they can even present in the hair-bearing areas. And if that happens, the hair that comes out will be lighter, and that's a hint of tuberous sclerosis for this patient. You can see that in this darker skin patient, you actually see the ash leaf spot or the nevus depigmentosus around both eyebrows. It's caused by changes in two tumor suppression genes, TSC1 and TSC2. And this is responsible for 85% of TSC cases. And why is it important? What do these genes do? They regulate cell cycle and differentiation. Interestingly, through a mediator called mTOR, it's interesting because we have a blocker for mTOR as well. Because this is altered, cells keep growing and growing without stopping. So here's TSC1, TSC2, and if that, if you don't have the brakes there, then everything downstream keeps growing and growing and growing, and that's why you get hamartomas everywhere. Interestingly, here's mTOR, and we have a drug called sirolimus that blocks mTOR. So could that be a target for therapeutics? Yes, it can. Two of the most feared complications are the growths that happen in the kidney and the growths that happen in the lung. The kidney ones are called angiomyolipomas. The lung ones are called lymphangiomyomatosis. Just knows that that can happen in both of these organs, and it can cause a lot of complications. But sirolimus can block this, or it can shrink down the angiomyolipomas. And it makes sense because it blocks mTOR, one of the signals that are there. And when they used this in the patients, they found that the angiomyolipomas did regress with therapy, but only when they're still on therapy, because they can increase in volume once you stop the therapy. And now there is actually everolimus, think of it as a second generation version of mTOR inhibitor that's licensed for treating the growth in the brain, the astrocytomas that can happen in patients with tuberous sclerosis. If it works for internal organs, and since this is a derm lecture, does it work for the skin? Well, people have tried using topical sirolimus, and guess what? It does work. If you stop, it can grow back. But in this patient, you can see how it shrinks down from here to here and from here to here. So practical pearls here is, in tuberous sclerosis complex, there's different cutaneous and even systemic manifestations that can occur at different ages. And it's good to know when things happen. The earliest sign, especially if patients are getting a good detailed fetal ultrasound, is a cardiac rhabdomyoma. But at birth, you can, if you notice the white spots that are birth, that's a good clue. And other clues that can happen with time, there's the infantile spasms as the seizures, and as they get to school age, the facial angiofibromas. And just know that it's important to know too, because there are treatments available for complications of tuberous sclerosis. Phew, so we've moved past neurocutaneous disorders. Now we're gonna move on to 3 genetic conditions with brown spots. The first is this asymptomatic 5-year-old with this finding. What finding is this? Buccal pigmentation. Here, 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 here. No one in the family has this. He has no other symptoms. What investigation should be done in this patient? A lot of things that we could do. The answer is genetic testing. But for what? Just because of buccal pigmentation? Yes. This patient actually turned out to have Peutz-Jeghers syndrome, and the only symptom was the buccal pigmentation. So oftentimes in the diagnostic criteria are to suspect Peutz-Jeghers syndrome, 1, 2, 3, and 4, they all involve PGJS polyps, Peutz-Jeghers syndrome polyps, a typical polyp that's there in the gut. However, in a patient who has suggestive findings, the molecular diagnosis can also establish the diagnosis of Peutz-Jeghers, and that's very important in terms of surveillance and what to do for this patient. So a recommendation from one of the position papers regarding Peutz-Jeghers syndrome: what's the risk of Peutz-Jeghers if you have mucosal freckling? What investigations should be done? If you just see the freckling in the mucous membrane, that's not diagnostic of Peutz-Jeghers, but it is worrisome enough. You should think about getting genetic testing done. Now, the strength of evidence isn't very high. weak recommendation, but everyone agreed, yes, you should do that. And that's what the case was for this patient. This patient came with just buccal freckling, and there was a pathological variant, a pathogenic variant in STK11. That's the gene for Peutz-Jeghers. So once you have the diagnosis, what organ is a high risk? The easiest answer is the gut, because the gut is at high risk. But that'd be too easy. What other organ is at high risk here? And the answer is the testicles. So in Peutz-Jeghers syndrome, oftentimes in textbooks, if you Google it, you'll think about the pigmentation and the gut. And we should think about the pigmentation and the gut, but it's more than just the gut that's involved. And in the gut, what you have is you have hamartomas that evolve to adenomas that evolve to carcinomas. So if you can pick it up early, you can take care of the cancer before it even becomes a cancer. However, other organs involve the pancreas, lungs, and reproductive organs. So with Peutz-Jeghers syndrome, you have these bluish brown to black macules, and interestingly, it can involve the lips, it can even involve the skin. But if it involves the skin, this can actually fade after puberty, so you may not see it anymore. But the buccal pigmentation still persists. So here's a patient where you can see the mucocutaneous findings in the lips, but also around the nose, but that can fade when the patients get older, but not in the mouth. If you see the freckling suggestive of Peutz-Jeghers, see if there's a positive family history, then more or less you probably have Peutz-Jeghers. If there's no relative family history, no GI polyps, get genetic testing done, because it's worth looking for in these patients. If it's confirmed, there are guidelines on what to do in terms of examination, but just know that in younger kids, you're going to look at their gut, either with scope or with capsule or MRI, but also you want to look at their, for the males, a testicular exam, because they can get malignancies in the testes as well. For females, the screening doesn't start till 18 years of age with breast self-examination and transvaginal ultrasound or other imaging at 25 years of age. Practical pearls here, it can seem like it's nothing, just buccal pigmentation, but beware of buccal pigmentation. There isn't a lot in the differential diagnosis, and you can make a big difference for your patients if you make the diagnosis. Notice that lip and skin pigmentation can fade with age, and in Peutz-Jeghers syndrome, it's more than just the gut involved. And for young boys, even in the pediatric age group, you're gonna make sure that the testicles are looked at after puberty. All right, we'll move on to another brown condition with genetics, and this is a girl, a 3-year-old female that has this large brown patch here. She has a G-tube as well, and you notice that there's pubic hair. What's going on here? What other organ system may be involved? And if you guessed the thyroid, you'd be correct. This is McCune-Albright syndrome, and classically the triad is bone finding, polyostotic fibrous dysplasia. This protein that's changed, you can have it as just a disease of the bone. But in McCune-Albright, it's bone plus the skin, where you get hyperpigmentation, and then the endocrine gland. The most common being precocious puberty, such as the pubic hair in that 3-year-old that we saw. Why does it happen? It's because of activating mutations or pathogenic variants in the GNAS protein. You only need one gene to be affected, and you get things to grow more. The endocrinopathies, they're all autonomous hyperfunctioning of the hormonally responsive cells. So you think about the skin in McCune-Albright, hyperpigmentation is usually the first sign of the disease. Now, you can have hyperpigmentation in a segment for patients who are totally fine. So on one hand, don't panic. There's something called segmental pigmentation disorder or pigmentary mosaicism. You just have a patch of lighter or darker skin. That can happen in healthy individuals. But keep in the back of your mind McCune-Albright syndrome, because there is not just the skin, but also the tissue underneath. It's usually ipsilateral to the skeletal lesions, and it rarely extends beyond midline, and you have this irregular serrated borders. So you can see a patient who has it. If you draw a line here from midline, you can see some of the pigmentation extends to the right and to the left with a sharp demarcation here. In this girl, you can see midline's a little bit skewed to her right, but it's all going onto one side of the body. But sometimes the pigmentation can be subtle, like in panel C, where it's a little bit in the neck and a little bit to the right of the buttock area. And it's like, which coast are you from? Coast of California, where it's more smooth bordered, like we talked about with NF1, or the coast of Maine, where it's more jagged. Typically, McCune-Albright is more of a jagged border that's there. So as opposed to the jagged border, you have the smooth border, like in a patient with NF1. So here's some pictures of different patients with McCune-Albright syndrome. You can see the border is a bit more jagged here, and here you can see this. You can draw a line right up and down the middle. You can see some of the brown going on one side and some of the brown going on the other side. Here, you can see it's on both sides of the back, but you can almost draw a line in the middle where the pigmentation goes up to it goes up here and it goes down again. What about the non-skin findings in McCune-Albright syndrome? Well, you have the fibrous dysplasia that often develops early, and you have in the femur, the pelvis, and skull base. You have symptoms with bone pain, fractures, or bony deformity. Commonly, you'll see precocious puberty, but as I'll show you, there's other endocrine organs that can be affected. And in males, penile enlargement will be the first sign of testicular tumors. So endocrinopathies, you get gonadotropin-independent precocious puberty. Basically, the genetic change causes hyperfunctioning of the gonads. You get ovarian cysts in girls, autonomous testosterone production in boys. You can also have growth hormone that's affected. Hyperthyroidism, you can have excess cortisol in the neonatal period, and then phosphate wasting as well. So what do we do for this? Well, it depends on what's affected. If you have fibrous dysplasia, watch for fractures, watch for scoliosis. Precocious puberty, you can block the puberty. Hyperthyroidism, treat the hyperthyroidism. Growth excess, medical therapy. Excess cortisol, and then you treat the neonatal Cushing's syndrome that's there. And then surveillance. If you have a patient where you're suspecting McCune-Albright, look for signs of hypercortisolism in infants. That's usually what happens in that age. But if they're children, watch for signs of precocious puberty and check the thyroid. And then for males, examine their testes regularly and do a testicular ultrasound. If they have the bony abnormality, the fibrous dysplasia, then you're going to do x-rays to monitor for that and then look at the phosphate levels. Craniofacial, make sure that the vision is fine, make sure the hearing is fine, and then skull CT. And if the spine fibrous dysplasia, watch out for curvature of the spine, scoliosis. In children with thyroid problems in ultrasound, but normal thyroid function, just monitor the thyroid function periodically. A lot that's packed in there, but just know at the entry point, if you see a patient with a large segmental capillary spot, especially with jagged borders, think of McCune-Albright. It's not enough to diagnose McCune-Albright, but just keep that in your mind. And know that it's a somatic activating GNAS pathogenic variant. So it's in one part of the body, not in every tissue. So you need biopsy of the affected tissue for genetic testing. All right, we'll work on to our last brown spot. And this is a 12-year-old male with multiple brown spots over the genitals. And I'll just preface this by saying, unlike other conditions like neurofibromatosis, which is pretty common, 1 in 2,000 to 1 in 3,000, this is an uncommon one. But with uncommon things, you want to know what things should make you think of these diseases. And for this one, he has a history of lipoma that was excised and confirmed. I have 3 lipomas on me. I'm 50 next year. Not uncommon, not rare to get lipomas, but a 12-year-old, really uncommon for kids to get lipomas. So if you see a lipoma, start thinking about things like this. Also has macrocephaly and facial dysmorphism and wart-like papules on the feet. This is how the face looks like, kind of elongated face. All these pigmented macules on the genitalia and on the feet, these wart-like lesions. What's going on here? If you want to guess what this is, you can guess in your mind. If you're watching this after the fact online, just take a pause. This patient has PTEN hamartoma tumor syndrome. If you haven't heard about this before, don't worry. Now you have. What is PTEN hamartoma tumor syndrome? It goes by other names. So if you thought PTEN hamartoma is bad, it used to be called Cowden syndrome or Banayan-Riley-Ruvalcaba syndrome. But once you found the genetic basis of it, which is in this gene called PTEN, they're all called PTEN hamartoma. You have changes in PTEN, and the key features, macrocephaly with or without autism spectrum disorder, lots of hamartomas, increased risk of malignancy, which is why it's important to pick this up, and then characteristic skin findings. So here, a slide that shows you all the different features that you can see in PTEN hamartoma syndrome. But if you look at the criteria for diagnosis, that might help us zone into things that are important. Macrocephaly is a very important thing to note. And autism spectrum disorder, things that are probably not, having a child diagnosed with autism isn't that rare, especially in a pediatric practice. But just know, if you have a patient with autism spectrum disorder, measure their head size, because that could be the tip-off. That's more than just regular autism that these patients have. And then sometimes, you don't look at all parts of the body. It's probably important to do that, because one other hint, it doesn't happen in all patients, but you can see this macular pigmentation of the glans penis, and that can help you make the diagnosis. Skin findings, you can see other skin findings. The acral keratoses, these are often mistaken for warts. So this is how the skin findings look like. These are the palmar and plantar keratoses. Thickened skin that's there, easily mistaken for warts. You can have gingival papillomas, neuromas. The tongue can have papillomas. You can tricholomomas. This is a fancy term for adnexal tumors, benign tumors that can grow oftentimes in the face. So what are the red flags? I mean, even pronouncing all the different stuff that's there can be hard to pronounce, let alone memorize. But these are things to watch out for. If you have a patient who has autism and macrocephaly, about 5 to 10% of them have PTEN hamartoma tumor syndrome. So as rare as this syndrome is, not rare if you have a patient with autism and macrocephaly. So keep that in mind. Also, if you see a patient with penile freckling with macrocephaly or autism spectrum disorder or intellectual disability, think about this syndrome. And also lipomas in children and having a big head. Lipomas are extremely rare in kids. If you see a kid with this and a big head, think about this syndrome. There's even this article that came out not that long ago talking about cutaneous lipomas and macrocephaly. That alone should make you think of PTEN hamartoma tumor syndrome. So practical pro, we're not going to make you a PTEN hamartoma expert. You don't have to be. Just know that if you see a patient with macrocephaly and autism spectrum disorder, think there's this other condition that can explain this. If you see a patient with penile freckling, which isn't that common, with macrocephaly, autism spectrum disorder, or intellectual disability, think of PTEN hamartoma syndrome. And lipomas and macrocephaly, think PTEN hamartoma. If anything else, look, macrocephaly, measure the head size of your patients. It might come in quite helpful. All right, we'll move into the last portion of our talk, which is 3 genetic conditions with red spots. Hopefully I haven't put you to sleep yet. So case history, 8-year-old female, red spots in the cheeks for several years, new red spots in her fingertips, lots of nosebleeds, and family members have a similar history and also arterial venous malformations. This is the kid's cheek, this is the kid's fingertips. What condition does she likely have? A lot of things here, but the one that should really make you, the one that you should really think about is number 5, hereditary hemorrhagic telangiectasia. What is this? This is an autosomal dominant disease, and there are good clinical criteria for this as well. Good-ish. Good in the sense that if you meet the criteria, you have it. If you don't meet the criteria, you still might have it. I'll go into that in a little bit of detail. The 4 things you ask for. Telangiectasias. There are usually multiple telangiectasias and in characteristic sites, lips, oral cavities, fingers, and nose. And there's no standard number for telangiectasias, but in a HHT, Hereditary Hemorrhagic Telangiectasia Center, they use more than 4. Epistaxis, they have recurrent spontaneous nosebleeds. And if you know, kids have nosebleeds all the time, but they use the criteria of like more than 4 per year and nighttime nosebleeds. But they also have visceral vascular lesions, arterial venous malformations, or GI telangiectasias, and a family history because it's autosomal dominant. Here's how the telangiectasias can look like: the cheeks, the fingers, the tongue, the ears, and then here's some of the AVMs that can happen in the brain, the lung, and the liver. How good are these clinical criteria for children? So the good of it is high positive predictive. If they meet 3 of the 4 criteria, they probably have HHT, and it's important to make that diagnosis. The bad is if they don't meet the criteria, they could still have HHT. And why? Well, the epistaxis in the telangiectasias often present later in life. So they could have it, but you can't say that they're fine early in life because they haven't manifested all the features. So even lower negative predictive value if the kids are younger. What genes are commonly involved? The top one, ACVR1, also known as ALK1, and endogliin, which is ENG. The genetics, these are the 2 most common ones, and then there are 2 less common ones that are involved. If If you look at the pathways, basically they're all involved in the same pathway. Can the genes predict the phenotype? In this case, yeah. ENG or endoglian, if you have that, you have a higher risk of pulmonary AVMs, and ACVRL1, higher risk of hepatic AVMs. SMAD4 is not that common to cause, if you look at patients with HHT, not a lot of them have SMAD4, but if they do, they often have polyposis as well. What do you do for these patients? Well, this is one case where it's worth testing asymptomatic children. It's a controversy in the world of, say, genetics. If you test someone, you find a genetic disorder that they have, but they don't even have it right now. You might cause more harm because they might be denied insurance or life insurance or health insurance. This is one case where it's worth testing. Because if you test and they're positive, you should even screen them for pulmonary or brain AVMs at the time of presentation of diagnosis. So if they're a child, lung screening, and all patients, brain screening. Look for anemia in these patients too, if they have a history of bleeding in kids. In adults, you're gonna do lung, brain, and liver as well. Because of the implications of this diagnosis and the worrisome natural history, you wanna look for it early and you wanna pick it up early as well. Practical pearls here, know the Kurokawa criteria. It's a clinical diagnosis. It's really just asking if there's a family. If there's multiple telangiectasias, or looking for telangiectasias, asking about nosebleeds, seeing if there's a history of AVMs, and then a family history. That's 4 things that are there. And if you have 3 of the 4, it's a positive, high positive predictive value for HHT. But know that it's limited, especially if the kids are younger, because they could still have it even if they don't meet the criteria at that point. But it's important to make the diagnosis because you want to screen asymptomatic children who have this. If they have an HHT parent, you want to do genetic testing, and if they're positive, even if they're not symptomatic, you're going to do the full screening for these kids anyways. All right, coming down the home stretch, 8-month-old female, red stain on the right leg, little purple blebs on the right shin, and the leg is longer. This is how the leg looks like, and if you look in the front, there's the little blebs that are there. What genetic condition would you think about? If you said Klippel-Trenaunay syndrome, you're right. Well, what is the gene involved? PIK3CA, and this is very important. Sometimes memorizing genes is like, yeah, but in this case, we actually have a blocker for PIK3CA. So knowing the gene is actually really important and really interesting as well. What's Klippel-Trenaunay syndrome? Classically, you have this geographic capillary malformation, venous lymphatic malformation, and overgrowth of the bone and soft tissue. And we have this activating variant in PIK3CA. PIK3CA, like a lot of the diagrams, it's involved in cell cycle growth, and PIK3CA is no different. Clinical aspects here, you can look at the shape of the capillary malformation to see if this patient has Klippel-Trenaunay or just a regular port wine stain, and look for abnormalities in the venous system as well. Not all port wine stains are the same. Just like for Sturge-Weber, same thing for the legs or the body in patients who have Klippel-Trenaunay. There's geographic stains, sharp demarcation, irregular shape, and a darker color versus what's called blotchy segmental one, which is not as sharply demarcated, which is a bit lighter. Here's a geographic one, very sharply demarcated. Here's it looks a bit like Italy. This looks like Italy. This is kind of like Greece. In contrast, here's a blotchy one. It's not as well demarcated, and it's considered a non-geographic one. It's important because if you have a geographic stain, it's very predictive of if you're going to get these lymphatic blebs that are there, and predictive of Sturge-Weber of Klippel-Trenaunay syndrome. You also have clues from the venous system. In this condition, you often have euplasia, hypoplasia of the veins, and then to compensate, you can have varicose enlargement of the veins and these persistent embryological veins that can be seen on the surface of the skin. Sometimes it can be just the surface system and you're lacking the deep system. It's important to know before you try to sclerose this that there is a deep system involved. Sometimes you have a good deep system, sometimes you don't have a deep system. If that's the case, you don't want to strip this vein, it causes problems for the patient. But having this dilated vein is quite commonly seen in patients with Klippel-Trenaunay syndrome. Management, well, the diagnosis is clinical, and if you want to get a tissue diagnosis, you have to biopsy the skin. because it's not in every tissue of the body. How do you treat? Supportive care. Because you have these slow flow vessels like veins and lymphatics, compression is very important. Because of slow flow, you can have clots. Pain management is very important too. You can debulk, and if you have a leg length discrepancy, it's very important to get your orthopedic surgeon involved. It's hard to walk or run properly if you have different lengths that are there. Medications, one called sirolimus, which blocks mTOR as part of the pathway, which I'll go back here. This is where genetics is interesting. If you look at the pathway, mTOR, that's a target of sirolimus, just like in tuberous sclerosis. And here, PIK3CA, well, there actually is a target for PIK3CA called alpelisib. This is a breast cancer drug, but it targets the same signal and can and has been used in patients with PIK3CA disorders. And you can do sclerotherapy if the lesions are amenable to sclerotherapy, but don't take out that embryological vein unless you have a good deep system. Surveillance, make sure that they're growing fine, make sure the legs aren't asymmetric. And it used to be thought that we should screen these kids for Wilms tumor. Now the thinking is they don't have an increased risk for Wilms tumor. And targeted therapy, it's a PIK3CA gene that's changed. There is a blocker for PIK3CA that has been developed. It's in the market for breast cancer, and it's starting to be used for some of these kids. The wider spectrum, PIK3CA is a gene. It can cause Klippel-Trenaunay. It can cause a whole bunch of other disorders as well, and they're all lumped into an umbrella category. Lots there, but just know that from a clinical and practical point of view, look for the geographic capillary malformations as a clue to Klippel-Trenaunay syndrome, and recognize the PIK3CA related overgrowth spectrum. If I haven't lost you yet, this is our last case. 11-year-old male, red spots over the face and body, feels pulsing over the face patch, and mom has similar findings. This is the kid, and he says, it always feels kind of hot there. You feel it, you can feel a bit of pulsation that's there. One of the clues for this is that you can see a bit of a halo, a lighter halo around the red spots, and sometimes they can look red or even red-brown. Why do you think he feels pulsations? He's excited to see you. AVM, pheo, sympathetic nervous system. It's because this is an arterial venous malformation. So what condition does he have? He has something called CMAVM, which stands for capillary malformation, arterial venous malformation. What is it? Well, it's a phenotype, and there's different genes that can give you this. Two common ones that can do it. You get multiple regular capillary malformations. You can call them port wine birthmarks or capillary malformations that are there. They're not as deep red as regular port wine stains. They can have this red-brown color. But more importantly, they have cutaneous and visceral arterial venous malformations. Two common genes that causes, one's called RASA1, one's called EPHB4, Ephrin B4 is the name of it. What do these genes do? They're all important, again, in growth of cells. Which cells? The vascular cells. Interestingly, it goes down a pathway where we actually have drugs that can actually block some of these pathways as well. What are some of the clinical features? In RASA1, CMAVM, you often have a positive family history. Not always, you can have a new genetic change, but it's autosomal dominant. You get these capillary malformations that are both right from the get-go at birth or also acquired. And they have this reddish brown color, often have a pale halo, and can be warm to touch. You get AVMs everywhere, including on the skin, and you can get overgrowth for these patients. Here, you can see that, you can imagine that around this pink patch, there's a little bit of a halo around there. Same with here. And it's kind of like this reddish brown color. And then you can see the progression of some of the AVMs that can happen in these kids. That's type 1. There's a type 2 that's very, very similar to type 1, but a different gene. And they also have characteristics of this disorder we talked earlier, HHT, hereditary hemorrhagic telangiectasia, where they actually also have telangiectasias and nosebleeds. So it's good to know that if you have a patient that seems to fit both features of CMAVM, but also HHT, it could be CMAVM type 2. The good news is that a lot of times if you're getting genetics to do a panel to look at genes, they have a genetic panel that encompasses all of these. So if you're testing for one and you're testing it in a panel, you can test for all of them as well. And here's some of the features that you can see of a CMAVM. You'll see the capillary malformations here, here, here. But one thing that's more specific, or you can see it in CMAVM type 2, are the little telangiectasias that are there, and then something called beer spots, these white pale areas that can tip you off to, hey, maybe it's more than just CMAVM, it's CMAVM type 2. Investigations, you can do molecular and genetic testing for variants, and then if you do find that patients have this, oftentimes you're going to do a brain imaging and spinal imaging to see if there's any arteriovenous malformations or arteriovenous fistulas inside the body. Treatment, if it's just a capillary malformation, consider laser. Don't laser a cutaneous arteriovenous malformation. You can actually make it more angry. If it is an arteriovenous malformation or fistula, consider embolization or surgery if possible. Watch out if they have an arteriovenous fistula or malformation. Basically, it short circuits the passage of the blood. You get more blood coming back to the heart, you can get cardiac overload. If that happens, refer to cardiology. If you get overgrowth of the leg, same thing for Klippel-Trenaunay. You want to make sure that there's no leg length discrepancy, refer to orthopedics. And then epistaxis, refer to ENT. Practical pearls here, consider CMAVM in patients who have red, brown, oval patches that have a pale halo. And just know that if they also have features of HHT, think of this other form called CMAVM type 2. All right, congratulations, you made it to the end. We've gone through 3 neurocutaneous disorders: Sturge-Weber syndrome, Neurofibromatosis type 1, and tuberous sclerosis. And these are ones that will probably end up on your exam. Good to know. 3 disorders with brown spots: Putz-Jaeger's, McCune-Albright, PTEN hamartoma. May or may not end up on your board exams, but they're definitely examinable. And 3 genetic disorders with red spots: HHT, Klippel-Trenaunay, and CMAVM. And if you're not exhausted, congratulations for making it to the end. That's the end of the show.
Another spectacular lecture, Dr. Lamb. Thank you. I don't know if your mustache is more spectacular or the lecture is more spectacular. I think they're both equally awesome. So thank you for going through those cases. I think, yeah, very high yield, number 1 for the boards, but really, you know, our training is not to pass the boards. Our training is to take care of patients, right? So I love all the references you shared, especially like with the cafe-au-laits. You know, that's something that we see commonly. I think that gets referred, like, do we need to work this patient up? And I think that table with the different, you know, what screenings are important is very good information to share with your families that come to see you for that. So great references, great photos. And yeah, just so much practical advice. And like you said, you know, screen the patients, look at their head size, look, you know, just take their weight and height, like, and just really keep your eyes open. And again, we're blessed to be dermatologists and see the whole skin surface. So take advantage of what we have, because I really, you know, the clinical practice of medicine, I think a lot of specialties have gone more into testing and just grabbing the, you know, the genetic diagnosis. But I think as dermatologists, we have that unique perspective. So yeah, so many great clinical pearls that hopefully all of the young doctors out there that are listening to this will not only pass their boards, but take great care of their patients, which is really our goal with T4.
Yeah, and one caveat too is like, what you know is what you know, but what you share with the family, you'd be careful too, because I have so many families that they hear the diagnosis of capillary spot, and then they're told, I'm going to refer you to a specialist. What do? They go on the internet. That's what I would do. And they stumble on neurofibromatosis, and capillary spots are not rare, but then sometimes, you know, they've lost sleep. So I like to think that, you know, the job of a physician is to worry so your patients don't have to worry. So you can kind of tell them, hey, we're gonna get this checked out. It should be okay if you think it's gonna be okay, but hopefully that they don't worry. The last thing to do is to tell them, hey, you have a capillary spot. We're gonna send you a specialist and leave it at that, because they are going to go on the internet. And just like, you know, I'm sure you know, Alana, being a parent, part of the parent's job is to worry for your kids. So, you know, you kind of steer them away from the sharp cutlery when they're young, because you know what can happen. So they don't even think about that. But, you know, if we can worry for our patients and think of all the possibilities and know, so we can worry for them so they don't have to worry, then we can, you know, we can definitely help them out.
Yeah, I think that's a great point too, because yeah, they're gonna worry. parents just worry. They're going to. That's part of pediatric dermatology, is not just diagnosing the patients, but managing the worry of the families. And again, if we can give them that anticipatory guidance, just like you said, and let them know, I see this, you may find something on it, or, and a lot of times the pediatricians will alarm them sometimes too beforehand. And then it's really, they come to you already with a sense of fear in their eyes, so yeah, I love the way you said that. Being able to worry for them is really a gift that we can give our patients. So yeah. Thank you. And topical sirolimus. So tell me about topical sirolimus with you. Have you used it with?
Yes. Yeah. In fact, we've even got different things. So in the patients with tuberous sclerosis complex, I think they found that when they treated the patients with either the kidneys or the lung stuff, then the facial angiofibromas shrunk down. It's like, hey, let's use this topically. And I think with kind of cringing, I think there's a patient that they used the sirolimus liquid on, because it's cheaper where I come from to get the liquid than to compound in the ointment. And I tried it for my patient, and the patient, that stung. I was like, really? Okay, I won't use it anymore. But it's kind of funny because there's a report of it working in a patient. I looked in the report, and there's a patient with developmental issues, and I realized, oh no, that patient probably stung too, but they couldn't report that it stung.
Yes.
but it works. It works if you use an ointment form. I think the most common complication I see from that is a bit of perioral facial dermatitis. So at least they know that these red spots that pop up, that can pop up, they're not angiofibromas. They're just, a nuisance irritation from that. But yeah, it works. And if you catch it early, if it's all fibrotic and stuff, and it's not red, and it's more skin colored and thick, I'm not sure if it works that well. And sometimes people still, you can laser it when it's early too, with pulsed dye or a vascular laser, when it's still quite red.
Yeah, absolutely. Yeah. And do you guys have well, I guess it's not FDA approved, but we have an FDA approved form now in the US, a topical sirolimus. Do you guys have access to that, or do you have to compound it yet?
It's still compounded here.
Yeah. And I've never used it on like a bleb of a vascular lesion in Klippel-Trenaunay, but it would make sense. I mean, it would totally be an off-label use. Have you ever used it there?
I use it for patients who have microcystic capillary, microcystic lymphatic malformations.
Okay.
And especially if they have leakage and if they have infection, and it works. I think there's a pediatric article or article in Pediatrics where they looked at topical sirolimus for microcystic lymphatic malformations.
Okay.
Find that.
Yeah. See, I learned something new every time you talk. Like,
there's so much stuff out there, and it's kind of neat to know that it's. I mean,
yeah,
some people have
it's
tried so many
better
different
when we
things.
put our brains together.
Totally. Yeah.
Yeah, but that makes sense that would work then. It, looking at the pathway. So yeah, it's not just for board pearls. It's really, helps our patients. So
Totally.
that's the fun thing about what we do. Well, very good. Well, I am so thankful for you. And tell everybody, if you would, for the questions of the week, you send out great questions of the week that I love to get myself by email. What's the best way for them to get question of the week?
Just, I'm happy to share my email address. Actually, if people are viewing this later, I'm not sure if it'll pop up, but it's just.
Well, we'll go ahead and I'll make sure that we put it on here and share it, just because, yeah, that's really helpful. And I love that you do that. And I swear, if I am ever on a trivia team, I am recruiting you, because not only do you know pediatric dermatology like so well, I swear, trivia like off the hook. So yeah.
For the case of the week, I think because they're actually patient photographs, as long as the email address is an institutional email, so it's not like a Gmail account or Yahoo account, I'm happy to email every week. We have different cases that are there. You can guess what the pediatric dermatology case is.
Yes. Wonderful. Well, thank you again, Dr. Lamb.